The Bander Center is a partial partner in helping bringing Wendell here today. And the Bander Center for Medical Business Ethics is an ethics center that's housed within the School of Medicine at St. Louis University. And we have a focus on education and research about issues in medical business ethics. We were established in 2007 with a grant from Dr. Stephen Bander and the BF Charitable Fund. And our highest hope is that today someone will get a spark from something that was said or meet another member of the audience and find something to collaborate with, to work on, and go out into the world and change it for the better. Our moderator today, Harold Braswell, is an assistant professor of healthcare ethics at St. Louis University. His work focuses on the intersection of bioethics and disability studies, with a specialization on disability at the end of life. His first book, The Dying Family, U.S. Hospice Care and the Crisis of Freedom at the End of Life, will be published this summer by Johns Hopkins University Press. He is currently writing a second book titled Inhospitable, How Housing Discrimination Shapes the Way We Die. Inhospitable, which is also under contract with Johns Hopkins University Press, will feature an ethnography of housing and end-of-life care in St. Louis. We are thrilled that our guest today is Wendell Potter. Without further ado, I'll give it away to you guys to get started. Thank you very much.
All right. First of all, thank y'all for coming out here. And thanks as well to Jason Kuhn, our fearless leader in the Bander Center, currently in India, I believe, and has really transformed this organization in a very cool way. My guest today is Wendell Potter. He's an author, former corporate public relations executive, and founder of the Philadelphia-based Tarbell.org, an investigative journalism nonprofit that focuses on how corporations and other special interests shape public policy and influence elections. He is also the president of the Business Initiative for Health Policy, an independent, nonpartisan policy, public education, and advocacy organization that advances the business and economic rationale for expanding Medicare to cover all Americans. He is also the host of The Potter Report, a podcast that explores how corporate and political propaganda influences how we think, act, vote, and spend our money. It's an excellent podcast, I just want to say. It's short episodes and really informative, and there are only a couple of them, so you could literally listen to the whole catalog on the ground floor, which is cool. Okay, Wendell was a newspaper reporter in his first career and covered business and politics in Tennessee before moving to Washington to cover Congress, the White House, and Supreme Court for Scripps Howard newspapers. In his post-journalism career, he served as head of corporate communications for two of the country's largest health insurers, Humana from 1989 to 1993, and Cigna from 1993 to 2008. Since leaving the corporate world, Wendell has returned to journalism and currently serves as Tarbell.org's executive director. He has also written 3 books. Deadly Spin, an insurance company insider speaks out on how corporate PR is killing healthcare and deceiving Americans. So this was a New York Times bestseller and winner of the 2011 Rittenhour Book Prize. Obamacare, What's in It for Me, What Everyone Needs to Know About the Affordable Care Act. And finally, A Nation on the Take, How Big Money Corrupts Our Democracy and What We Can Do About it. These books are excellent, I should also say. Deadly Spin is a really important book that I highly recommend. Okay, so without further ado, let's get started. So I think we're going to go back and forth for about 35 minutes or so, and there should be time for questions, and then afterwards we'll be hanging out and getting coffee, so please do stay. All right.
Very good.
Wendell Potter. So let's just start with your story. So you're an insurance industry insider, and now you've moved to an advocate for reform on the outside, external critic. How and why?
I've often referred to it or talked about it as a crisis of conscience, and I came to realize that, frankly, what I was doing for a living was the exact opposite of what I tried to do as a reporter. I tried to be objective and fair and straightforward, never intentionally misleading people. But in 2007 in particular, there were a series of things that just made me realize that what I was doing and what I was being paid well to do was to mislead people, was to perpetuate a very broken, dysfunctional, unfair, expensive healthcare system because it works very well for my industry, the companies in my industry, and most healthcare providers. I happened to go back to Tennessee where I grew up in the summer of 2007 and went to something that's referred to as a healthcare expedition put on by this organization called the Remote Area Medical. And that experience was an epiphany for me, or I often refer to it as my road to Damascus, because I came face to face with people who were standing in line waiting to get care that was being provided in barns and animal stalls on the county fairground. And I just realized at the moment when I walked through those gates at the fairgrounds that I was at least partly responsible for it because of the work that I had done to mislead people and to perpetuate the system that made it necessary for Americans to get care that way. And I realized I could have been one of them if I hadn't been lucky. And our healthcare system, unfortunately, you often are lucky or unlucky, and our healthcare system is one in which we ration care based on ability to pay.
All right, well, so we're going to talk about what you think is wrong with healthcare financing today and what solutions, but I want to stay with, inside the insurance industry for a little bit, because that's a perspective that you have that a lot of us don't. So when you were working in the industry, you came to this sort of epiphany in 2007. So what did you think before then, and what are the forces within the insurance industry that basically encourage people working in it to think of it as an ethical enterprise, right? I imagine most people inside the insurance industry, they're like, anyway, we don't think that we're doing bad things. So what are the forces that sort of create that culture? And what do you think it is about you that led you to kind of see things differently, ultimately?
Well, going into my job, and I really started working in healthcare in Tennessee in the mid-1980s, and I became very much an advocate and a believer in managed care and what it could mean to help people get access to care and appropriate care. And I was also a firm believer in the notion of the free market, and that the free market could work in healthcare like presumably it works in other sectors of the economy and society. I came to realize that was not the case over the course of my career. I came to see that the free market actually in healthcare works the exact opposite in many ways and contributes to a lot of the dysfunction and expense of our healthcare system. But there are a lot of people, even I for many years, would see the role that I played in a positive light, and I often would essentially pat myself on the back that I was maybe helping someone get the care that they needed because of some of the work that I did, and I had risen to up through the ranks and worked very closely with the CEO and other executives, and I enjoyed that position, and my title became kind of intertwined with my ego, and I had a chance to work with, part of my job was to work with reporters at the Wall Street Journal and the New York Times. I went to New York a lot, but also to Washington. I was involved in working with our lobbyists and trade associations on issues of public policy, and also to develop PR strategies to help push back against any efforts to reform the system in any way that might harm profits. One of the things that I remember very vividly that during the time that I was very proud to work for the companies I work for, one of our chief medical officer at Cigna for a while was someone I greatly admired. He developed something called an ethical decision-making tool. We had a lot of medical directors around the country, and this tool was to help medical directors walk them through a process of determining, is this decision that I'm about to make one that I feel is ethical? Are there pressures on me that might be influencing my decision? And these people have enormous power. They are the people who often stand between a patient and his or her doctor to get the care that they need. Unfortunately, that chief medical officer he wasn't around very long. I think the executives felt that maybe he was too ethical, quite frankly. And I became someone who also began to question what I was doing, particularly when the industry decided to move away from some of the principles of managed care and to move all of us into high deductible plans. And I was expected to be a cheerleader for those plans. Most people, though, didn't have the perspective that I had. You can work day to day in your job, your department, and be completely unaware of how decisions are being made in the so-called C-suite. And I don't recall a single time in my last few years working with the investor relations department and the CFO and other executives in which anything other than numbers and dollars were being discussed, and whether or not the company was going to be meeting Wall Street's financial expectations the next quarter. That's what the conversations are. It's not about how can we be a better corporate citizen, how can we as a company help people get the care that they need when they need it. It's all about the money.
So last question on this sort of, so, you know, we have a number of students here and people like me that, you know, could be in similar situations, right? Working in an organization that, you know, that we come to realize may be unethical. Why do you think, so you're rare as a whistleblower, okay, as somebody on the inside who can't do this. What do you think it is about your background that kind of sensitized you to see these things, that there's an entire culture oriented towards obscuring, not just obscuring, you know, just saying that we're doing the right thing. What do you think about you and your life experience made you sensitive to these things?
I think it was the way I was raised in a family that my parents were very caring folks. They were not wealthy by any means. When I went to that healthcare expedition I mentioned, one of the things that I realized was that I could have been one of those people in those lines had I not been lucky, had my parents not saved money so I could go to school, get a good education, and ultimately get a very good job. I've had, you know, been very lucky to have a successful career in journalism and corporate PR. I guess just because of my parents, quite frankly, and the way they raised me, I was, I think, more likely to be moved by that scene. And the other thing is that most people stay clear of something like that. I've often talked about what it's like to be a CEO of one of these companies. I traveled with him a lot. I traveled on the corporate jet a lot. The CEO at Cigna, I liked him, but he would be picked up in the morning at his home, driven by a driver to his office, even take an elevator that was not one the rest of us used to get to his office. He never went to the employee cafeteria. When he would have to go to a meeting, he would go down that private elevator or to that private car waiting for him, go to a private hangar. It would take us to a meeting and on a private jet. And when you live a life like that, you can steer very clear of the way other folks live and be completely unaware of the fact that people are having to get care in barns and animal stalls. And I somehow willingly went to that expedition. I think it was, there was something that kind of led me to that. I think I was, well, I know, I was already kind of, I was questioning what I was doing for a living, and without even knowing it, I felt it was something important for me to see. But you rarely ever see a corporate executive go to those places and, or even contribute money, which they probably shouldn't, because it's not a real safety net. Unfortunately, it is, for many people, the only thing that passes for a safety net.
Do you think it's possible, you know, we're at a university, it's an educational institution. Do you think it's possible to teach people to become whistleblowers one day, to sort of see the things that you learned, that you're attributing to your parents and your upbringing? Do you think we could institutionalize that?
I absolutely think we can, and there are some organizations that try to do that, and one of the things that we hope to do at Tarbell is to be a place where whistleblowers, people who have information about the workplace or where they work that they think the public should know. We want to be kind of a safe haven, a safe place for that. Absolutely. I think it's extraordinarily important. But it's a terrifying thing to do, absolutely terrifying. I've been called a whistleblower in a sense. I'm not, I guess, technically or legally a whistleblower, because in the legal sense, it is someone who is divulging some information about fraud and a company defrauding the government, What I did was talk about industry-wide practices, not things that were specific to Cigna. I've been called a whistleblower. I'm fine with that because the way I often say it is I kind of pull the curtains back to help people understand how the entire industry really operates and what I used to do for a living and the tools and techniques of public relations that I used and my colleagues used to shape public opinion. The tools themselves also are not evil. They're just, well, some of them are. But there are ways of persuading people to believe certain things. One of the things that I would say is not a useful public relations tool is a front group, and we set up a lot of front groups over the years to make people believe that they were grassroots organizations, but they certainly were not. They were industry-funded AstroTurf groups or groups that disseminated propaganda.
Brief plug for the first episode of the Potter Report, which is actually about propaganda. And I think that's sort of what's really interesting about Wendell's perspective, because there are a lot of people writing about sort of healthcare reform and problems, but this sort of the role that PR causes, has in creating consent and creating sort of a belief in this, he gets really powerfully.
Well, thank you.
All right, so what's the problem with healthcare financing today?
There are a lot of problems with the way healthcare is financed in this country, but I think the biggest problem is we have a multi-payer system and we have third-party reimbursement for care that is available to some people but not to everybody. It's a very inequitable way of providing financing and access to healthcare. When you have a multi-payer system, I've come to realize, even though I was an advocate of the system that we have for many years, you have a lot of companies like the ones that I work for whose their principal objective, the reason for to exist is to enhance shareholder value. It is not to bring more people into coverage. It is to ensure people who are the healthiest and to do what you can to call out those who might cost the most. It is a system that has resulted and contributed to a rising number of people who don't have insurance, but an equally bad situation in which a lot of people who have insurance are underinsured and they can't use their policies because of the high deductibles that are a feature of most health plans. And when you have multiple payers, it creates an enormous waste of resources. You've got within each health insurance company a large staff of people who are engaged in work that doesn't really add value, in my view, or at least help people get the care that they need. You have underwriters who are who work to try to figure out how much to charge someone for a policy based on their health status. You have doctors and nurses who are making decisions on whether or not someone will get the care that they need, who deal with this thing called prior authorization, that is a way in which people are not getting the care that they need even though it's a covered benefit. And this system that we have too also requires that doctors and hospitals have to have staffs, teams of people in some cases, who do nothing more every day except deal with people at insurance companies to hopefully make sure that they are paid appropriately and that their patients get the care that they need. It's extraordinarily inefficient, and no other company and no other system in the planet operates like ours. And we have a system too that most people who are not covered by a public program like Medicare or Medicaid get their coverage through the workplace. And that's not good either, because if you are in an employer-based plan, you are just one layoff away from being not only unemployed but uninsured, and usually not just yourself but your family. And it's just a structure, a system that clearly no other country in the world would ever emulate. It's one that just kind of developed without any kind of government oversight or plan.
All right, so what's interesting to me is that, what you just said makes a lot of sense to me. It's clear, you don't have to be like a genius or super complicated to understand it. And in fact, most people, or a lot of people at least, have negative experiences in our healthcare system that might lead them to sort of a view like that. Yet there's a lot of resistance, and I guess I'm wishing you could talk from the PR perspective. So what role does public relations play in creating a different narrative for understanding healthcare in America?
And that's a good way of putting it, because we wanted to shape the narrative. We wanted to shape the way the public views our healthcare system, and to be afraid of any kind of an alternative and to denigrate any kind of alternative. I spent a lot of time in my old job getting people to be afraid of the Canadian healthcare system in particular, but also the NHS in England and any other system that is not like ours. You want to perpetuate this notion of American exceptionalism, that no one can have anything better than we. And that obviously the Canadians don't have this figured out, and that Canadians are flocking across the border to get care here, which is another lie, another myth. But you can perpetuate that. I can't tell you how many times that I've spoken and someone will say they've heard, and one of their relatives knows that people are coming across the border to get care in American hospitals. It is a myth. And you can hire think tanks. I'm using the word lightly, but they call themselves think tanks. But they're really also propaganda machines to perpetuate this. And you can use terms, I wouldn't put out a press release that wasn't reviewed very carefully, or use talking points that wasn't message tested, often focus group tested, to make sure that it would resonate with people. You want to connect with people emotionally. So you don't necessarily use true facts and figures. You scare people. There's something that has the acronym of FUD, FUD. It's fear, uncertainty, and doubt. And these PR strategies that we would create and implement were based on that. You want people to be afraid of change, to be uncertain about how you would fare under a different kind of system, and to doubt that those who are purporting it are looking out for your best interest. We were experts at that, and you're going to see it again. One of the reasons I left my job when I did is I knew that I was going to be having to be engaged in that kind of work again, to try to try to keep healthcare reform from being enacted in 2009 and 2010 if I had stayed in my old job, because I had done some of that work in the 90s to kill the Clinton healthcare reform plan, and we were successful.
So your most recent book, Nation on the Take, is about lobbying. What's the lobbying piece of this? So what role does lobbying play?
It plays an enormous role. It's a big part of the reason why we have the system that we have, and it's so hard to move away from it. Money is used in many different ways, and lobbying is one of those ways in which you can keep track of it. One of the things I noted, one data point in Nation on the Take, there's a chapter about the drug pharmaceutical industry and how it has been able to pretty much call the shots in Washington and state capitals. But that industry spent more than even the insurance companies or anybody else during the reform debate that led to the Affordable Care Act. They spent collectively, the pharmaceutical industry, $275 million just to lobby on that one piece of legislation. It was the most that any industry has ever spent in a year on a single piece of legislation. But the insurance industry spent tons of money as well, but money is spent also to influence elections as well. And a lot of it can be accounted for. A lot of it can't, because it's spent through dark money in ways that it goes to organizations that really don't have to disclose where the money's coming from. And of course, it's used to influence public opinion. So the money is just enormous to influence public policy in so many different ways. But lobbying, the industries have at least one lobbyist for every lawmaker, if not more. When I was a reporter in Washington back in the 70s, there certainly were lobbyists, but nothing like the number that there are now, and it just exploded.
So we've been talking about the problem. What's the solution to the problem with healthcare financing?
The solutions are, one, since we're talking about money, that's one thing. I've talked to, obviously you're talking to a lot of folks all the time who are interested in reforming the healthcare system, but we also have to pay attention to money in politics and address campaign finance laws. And that crosses everything. It's not just healthcare, but that if you are concerned about healthcare, also be concerned about that. It's important for you to also have an interest and a concern and to try to advocate for appropriate change in the way we special interests are able to influence policy and elections. But I think we also, specifically about our healthcare system, we need to move away from this employer-based and multi-payer system that is so inefficient. I said after the Affordable Care Act was passed that I felt it was important to pass it. It does some good, but what it did was leave in place the basic structure of our system. I've sometimes referred to it as tinkering with the system and making it a little bit better. An economist a healthcare economist who I liked referred to it as a Band-Aid, an ugly Band-Aid on an ugly system. And it is pretty much that. It did bring a lot of people into coverage, and it made some of the practices that I've talked and written about unlawful, but has done very little to rein in healthcare cost. It is not transformative legislation. We need transformation, not just healthcare reform. We need to have a different chassis, if you will, for our healthcare system, one that is not keeping in place the special interests as they are, but moving to Medicare for all, or single-payer health care, as it's often referred to, in which there is a large, one large pool of people, and the resources are managed by an expanded and improved Medicare for all, or I guess the Center for Medicare and Medicaid Services, but moving away from this fragmented system that we have now that's incredibly inefficient.
So what are the steps that we need to get there? And are you seeing any political actors right now or any sort of movement in that direction?
I have, and it's just almost astonishing to see the change that has been taking place. When I was beginning my career, when anyone would mention single payer, it was almost laughable. There have been advocates for this for decades. Physicians for National Health Program goes back decades. So there have been a lot of people who've been advocating this for a long, long time. In fact, even back to Harry Truman, who was suggesting that we needed to have a more rational system, sort of like what we're talking about now. And my old industry pretty much knew that it was not going to happen because the industry was so powerful and the advocacy groups were so disorganized. But that's beginning to change. We're seeing a lot of policymakers sign up for the bills that are in both the House and the Senate. There's been a bill that's been introduced in the House many, many times. It's most commonly referred to as H.R. 676. Now that bill has a majority of the Democratic caucus as sponsors and co-sponsors, and that will even increase when the new Congress is sworn in January. There is now, for the first time, a Medicare for All caucus within Congress of about 70 members, I think. And on the Senate side, Senator Sanders introduced a bill a little more than a year ago, and it has 17 sponsors, I think, at last count. And that's extraordinary. That didn't exist. And I think Senator Sanders, by the way, came at a very important time in our country's history to give legitimacy to the notion of a single-payer Medicare for all system. He moved it from being pie in the sky, a pipe dream kind of thing, to one that people began to understand and see that it's something that is a possibility. And I think we're beginning to see, I think it's an inevitability. The current system that we have is just simply not sustainable. In the talks that I've been giving, I use a series of slides to help people just understand what has been happening to us in our healthcare system and how we stack up with other countries to kind of lay the predicate, if you will, or just help people understand, when you see visually, you can see that the current system is not sustainable. The other thing that I'm seeing is that employers are beginning to realize that they've been sold a bill of goods by the insurance industry over many years. They can no longer afford to provide coverage to their workers. Insurance companies honestly don't, they talk a good game about controlling healthcare costs, but they really don't, they can't, nor do they have a real incentive to do that, because the more healthcare costs go up, the more, because they're the only game in town right now, they're able to raise premiums every single year. That brings in more revenue, more money that they've got to convert to profits.
All right, so I'm optimistic. I'm feeling good then. But there's this guy who's president, and his name's Donald Trump. And it's interesting because all of your books are written before the Trump presidency. Yeah. But if you read them from the perspective of the president, the present and president, they're sort of like breadcrumbs leading to where we are now. So can you start just by talking about what's your take on the rise of Trumpism, sort of broadly, and what role has the health insurance industry played in stoking the kind of anti-immigrant or kind of sentiments that have brought us to this point?
Yeah, I think we have the president we do because I don't think Democrats in particular were paying very much attention to the electorate, to people's, people are hurting all over the country, and I don't think that a lot of the Democratic candidates and Secretary Clinton really understood that, and I think that Trump is president because somehow he tapped into the frustration that so many Americans are feeling and saw him as someone who, because he was not part of Washington, might go in and shake things up. I think that's primarily what it is. People are really fed up with the status quo in so many different ways, and they see politicians who've been around for a long time as actually part of the problem. So I think there was hope that this guy might follow through on some of the things that he said. And, but he also certainly, I think, tapped into racism in this country. There's a lot of fear of the other in this country, probably everywhere. It's not just this country, but certainly was able to stoke that, to benefit from it. I think that it's an administration that is trying to take us back to the days before the Affordable Care Act. As you know, Republicans in Congress tried scores of times to try to repeal the Affordable Care Act. They didn't. They can't now because it's nothing like that's going to get through the House. But the administration, through executive orders and just some things that the administration is able to do, they are trying to, well, they are succeeding in taking us back to a certain extent. One of the things that is likely to happen is the giving the states or giving insurance companies the ability to sell junk insurance that is very profitable for the industry, but is just terrible. So I think we'll go back a little bit, but we're not going to see the Affordable Care Act destroyed. But it's going to be weakened, and we already are seeing people, the number of uninsured Americans go up. So the Affordable Care Act is not going to bring more people into coverage. It's and also the way it's structured, it is more and more of us are in the ranks of the underinsured because it does nothing to end these high deductible plans. But I don't think that over the next 2 years we're not going to see the Affordable Care Act undone. We're not going to see Medicare for All legislation passed because of the control of the Senate. But I think that we're going to be seeing a lot of candidates campaign on moving toward a single-payer Medicare for All system. Pretty much every one of the Democrats who have aspirations for the White House have claimed to support Medicare for All. There's going to be a big pushback against that by the industry. The industry is seeing that this obviously is happening. So they will be advancing proposals through the Democrats that they can influence through campaign contributions and lobbying, and there are a lot of them. Corporate Dems, I call them. They call themselves often moderate Democrats. There's this organization called the New Democrats, which is largely corporate funded and allied with this outfit called the Third Way, which sounds great, advances the notion of bipartisanship, but most of the funding comes from corporations. They'll be advancing this notion of Medicare for some, Medicare for a few more folks, maybe reducing the age of eligibility or having a Medicare buy-in. Those will be measures that will be put forward as something that's less disruptive than moving the country to a Medicare for all system. But so no, that's coming as well.
Founder, do you want to open it up?
My question is, you had talked about whistleblowers, and thank you very much for your work in this area. I see a parallel with social media companies now, the way that sort of their public-facing mission of compassion and, serving people is really sort of not the actual mission, which is corporate greed, and lack of integrity in pursuing that. And I wonder, is healthcare too complex for journalists to take a similar role to sort of expose these things?
Yes, unfortunately. Some of the talks I give are about what's been happening to journalism in this country and around the world. And most of the media is corporate owned. A lot of newspapers have been shuttered, and thousands of reporters have lost their jobs. There's very little investigative reporting done. One of the reasons I decided to start Tarbell was to try to push back against that trend. And I observed this during the last years of my job at Cigna. I was the company's chief spokesman. My team and I handle all the calls from the media. At the beginning of my role, we would get calls often from reporters all over the country, certainly where Cigna had operations. And toward the end of my time there, almost all those calls, they just weren't coming in anymore. A lot of the reporters had lost their jobs. Even some of the publications were no longer around. About the only calls, in fact, I think the last day when I was on the job was in May, and I had agreed to stay on until the company announced first quarter earnings. They didn't have anybody else at that point to do it, so I agreed to do it. And the only reporters who were calling about anything pertaining to how we did business and whether or not we met Wall Street's financial expectations were reporters with Dow Jones and Reuters and Bloomberg. The stories they would write would not show up in the general media, but they were writing for investors. They were writing for Wall Street. Even the Wall Street Journal and the New York Times had stopped calling by that time. And with the decreasing number of reporters who are assigned to cover healthcare, that means those that are left to do it, they have a very superficial understanding of how the healthcare system operates. So my job was pretty easy because reporters didn't know much. It was easy to pretty much have your way with them. I mean, I can't say that I was batting 1,000, but I was almost always able to make sure that the company's point of view was included in the story, and often to shape a story just because of a reporter's ignorance or lack of depth of understanding.
Some people, by far the minority, who are completely on board with doing whatever we can to see that everybody, especially everybody in our country, receives health care. And yet, they're convinced that there are some medical services that are not truly serving the health of patients. So, for example, whether it be abortion or contraception or some assisted reproductive technologies, in vitro fertilization. Is there any response? I don't know if you've been in dialogue with people with those kinds of views. You know, what do you say to them who want to do everything and yet they are concerned that there's no way they can jump on board with expanded Medicare without violating conscientious objections?
It's always going to be an issue because that is an issue of great concern to a lot of folks. I mean, that's their thing. And the legislation that advances through Congress either will or will not have authorized coverage with dollars from the federal government to pay for abortions. Right now, it's not a possibility. You can't. Federal programs cannot do that. But it's contentious. It's just got to be something that is in or is out, and some legislation, actually, like the Hyde Amendment, will have to be addressed if there is to be money that is available to pay for abortions or reproductive rights. But there are other issues too that it's not going to be easy to get there, to have a piece of legislation that everybody, including single-payer advocates, all of them are going to agree with. There's a difference, for example, in the House and Senate version of the bills right now. In the House version, which is not as well fleshed out, it's often referred to at this point as a messaging bill because it doesn't have a lot of specifics, a lot of granularity. It would make it unlawful for the federal government to provide reimbursement to for-profit hospitals and nursing homes. It's not in the Senate bill, and under the House bill, for example, the expectation was that the government would actually buy out all these for-profit facilities. That would be enormously expensive, and Senator Sanders decided not to have that in his bill. So, and the Physicians for National Health Program and the California Nurses Association and National Nurses United, they are the two organizations that have been advocating for this kind of a change for years and years and years. They don't see eye to eye on this. From the nurses' perspective, the California Nurses, National Nurses United, they see this as a lot of their members work for for-profit hospitals. So there are a lot of contentious issues. There are a lot of things that have to be addressed along the way. Some people will be happy, some people will not be. I'm hopeful that a lot of these differences, at least in the early stages, I'm not saying they should be ignored, but there's a lot of work that has to be done to create legislation that has the most support. But I mean, going forward, you just know there are going to be some areas and some very significant areas of a difference of opinion.
Hello. I have kind of a two-part question. First, I was wondering about the notion of deservingness in the narrative that the insurance company tries to spin, or at least was going to spin. And then how does that interact with the fact that the U.S. has a specialized healthcare system for certain citizens? I'm talking about the VA. It's closed to outsiders. And how does that all come out in the mix? Or what impact does it have?
Be a bit more specific about deservingness. What?
Yeah, the notion of deservingness, like we don't want to care for immigrants because they are the other,
Yeah.
or we do want to care for this person because they have a job. So if you have a job and you're employed, that means you're worth health insurance.
Yeah, the issue of immigrants is also obviously very contentious and very divisive. In California, for example, there's more support among policymakers there and citizens. There's, in fact, quite a bit of support for California moving forward with a state-based single-payer system. And there's been legislation in Sacramento that could really gain some traction next year because Gavin Newsom, who's the governor-elect, advocates for he supports a single-payer system. We'll see. But there's a lot of support for making sure that there is coverage for immigrants and even those who are undocumented, because they use and have to have healthcare services. They use the emergency room, and other parts of the country that's a non-starter. So it's another one of those things that divides our country and point of view. This just got to be addressed as we go forward. Should we have a system? I know that one of our journalists was in the UK not long ago. His daughter was graduating from Cambridge, I guess it was, or Oxford, and he got sick while he was there. He had to go to an NHS hospital. They cared for him. He's obviously not a British citizen. Had very little expense. So I don't know exactly how it will play out nationally when we really get to the point of having to address that. There will be a lot of resistance to include coverage for undocumented folks. But we've got to come to terms with the fact that they are here and require services and should not resort and have to resort to getting care in the emergency room, which was obviously expensive and not appropriate for a lot of folks. I don't know. There is also this notion of I don't want to pay for even a U.S. citizen who, in my view, is not worthy, not deserving of care. And also the concern that if we bring more people into coverage, then that's somehow going to reduce my or have a negative effect on the care that I get, and that it's a zero-sum game. That there are there's not enough to go around, and I've got mine. I want to keep mine. I'm even hearing this from people who are enrolled in Medicare. They are resistant to expanding Medicare to cover everybody. I've waited all this time to get into Medicare. I like it. I don't want to expand this, and because that might make it less likely that I can get the care that I need. Yes, sir.
So is it only money and politics that is keeping competition from having an effect and bringing more costs to the healthcare industry, or are there other systemic problems with the way we deliver it that prevents that?
Could you repeat the question for people?
Yeah. See, is it politics that is keeping, I guess, competition from really working in healthcare?
The free market that everyone touts.
Right.
How come it has no effect on the healthcare industry?
Right, right. I was just on a radio show yesterday with someone who advocates and says we just really need to get government entirely out of healthcare, that the free market will work its magic. Sometimes said that, you know, in fact, I can recall writing speeches for the CEO in which I would say that the government needs to get out of the way and let the invisible hand of the market work its magic. In healthcare, though, that invisible hand often has just one finger. But it doesn't. What we have is largely an example of market failure, and healthcare, it doesn't work. You have a situation in which people can't really shop for services when they're very ill, when they've just been given a dreaded diagnosis or injured. You don't have the time or the presence of mind for you or anyone else really to think about shopping for a hospital where you might get a better price. In fact, I'm not sure that I would necessarily want to go to a cut-rate hospital. You know, there are reasons why it doesn't work. There's not transparency in this country in terms of pricing. What something is listed almost has no meaning because of the various ways that the third-party reimbursement system works. But as I said, I think it often works the exact opposite. And also, let's say that the government gets entirely out of health insurance. Let insurance companies offer the policies that a young man might want, for example, that doesn't include anything, no coverage for maternity care. And a lot of guys, well, why can't I get that kind of a policy? Well, that means if that would mean that policies that do include maternity care would be a bit more expensive. And so there's a discrimination against women. In fact, before the Affordable Care Act was passed, insurance companies did discriminate against women. Women were charged more for the same policy than young men or men of equivalent age were charged. And they were able to offer policies that didn't cover pre-existing conditions. Today, maybe I don't have a pre-existing condition. I'll sign up for that policy, and that's good for me. People don't realize that as you get older, you're probably going to wind up with one or more pre-existing conditions. So people are not thinking ahead even for themselves or their family. But that means when those policies exist, people who do have pre-existing conditions are going to have to pay more for it. So even though this guy was saying that we have an insurance system that is pretty highly regulated, it is often referred to as a patchwork of regulation because health insurance is largely regulated at the state level. It's still, insurance companies have a lot of latitude, and the Trump administration, through some of its actions and through CMS, wants to take us back to give insurance companies at the state level more latitude to sell those old policies again. And many of them are junk policies. Why do we want our folks to be enticed into plans? Cigna and Aetna used to market these junk insurance. They were referred to as limited benefit plans, and a lot of folks who were of limited means would see these policies and see that they had relatively low premiums. And the reason they have low premiums is because they don't cover much of anything. And insurance companies love these because they were getting money from these folks, often unaware of just how limited the coverage was. And they found out when it was too late, they got no coverage. Why do we want to go back to that? Why do we want the free market to let us be susceptible to that kind of stuff? It just doesn't make sense to me. But there are always going to be folks who say that get the hell out of health care. The government get out of the health care and let the free market do what the free market does.
And we probably have time for one more question.
I think as you talk about Cigna and Aetna, many of us think about employer-sponsored insurance, insurance that people buy that we call private insurance. I think everything you've said today also applies to our Medicaid and Medicare systems. In Medicare, we see Medicare Advantage plans, which are really insurance companies doing the exact same thing you've
right.
talked about.
Right.
In Medicaid, it's called Medicaid Managed Care. And we happen to be in St. Louis, and St. Louis happens to be the home for the largest for-profit Medicaid managed care company in the country, Centene.
Yeah.
And as you speak, I think about all the ways that Centene is perceived as a very good citizen. They fund a lot of arts, a lot of important community activities. They hire a lot of our alums from the law school, the medical school, the accounting school, the business school. I don't know about the School of Public Health, who feel very, very good about the work they're doing.
Right.
They feel like they are at the cutting edge. On the other hand, our Medicaid department issued a report looking at their quality indicators, comparing it to Medicaid that's not managed by a for-profit insurance company. Found that the quality indicators were better in fee-for-service Medicaid overall, that the administrative costs were lower, and that where Medicaid managed care was saving money was by lowering the rates they paid providers. And we all know that in Medicaid, the difficulty is that because we have multiple payers, the lowest payer are the patients who get left out. And that was done as part of a policy initiative. The question was whether we should expand Medicaid managed care and insurance companies here in Missouri. And that was pretty powerful data. We did it. Why? Because of campaign contributions, because of lobbyists, everything you've told us. So that's my long wind up to a
Yeah.
question of how do we continue the conversation you've started today about the ethics here at the local level, talking, with and about Centene, knowing that there are good individuals there trying to do the right thing, but we've created a corporate entity that does the wrong thing.
Yeah. And thank you for that. And you're exactly right. And I was involved. I often said that in my shop at Cigna, my PR shop, we had an offense and a defense. And part of the offense was to make people see that we were good citizens, and it's buying goodwill. I also led for a time the Cigna Foundation. So we would dole out money to a lot of groups around the country, and we'd send out a press release about that. And it's over time, and those organizations to get that money, they're going to be there. It's sort of like the way the drug companies give money to disease groups. You do that because you want them to be there for you when you have a policy issue. Two or three things. One, I'll go back to what I said before. We've got to have a focus on reforming our political system, our system of campaign finance and lobbying. And some, like say even South Carolina prohibits lobbyists from making campaign contributions. I mean, there are a number of things that can be done to reduce the power and influence of these corporations. Another is to help people become more aware of what's going on through their PR efforts and their charitable giving. What that really is doing is buying goodwill and having people see the company in ways that is not necessarily all that accurate. But also, one of the things too, if you've got the time to do it, is help people understand what's the financials of these companies. Well, they have, it's a publicly traded company. They announce earnings every 3 months. Become an expert on how, and listen into what those executives say to the Wall Street financial analysts on these calls. That's when they really tell the truth. But it's a very significant audience for them, but one that the rest of us never sees. Just helping people, I guess, better understand what the company is. And also, here's something that most people don't know. Certainly Centene is in this business of Medicaid managed care. And they've been extraordinarily successful in persuading lawmakers at the state level to turn their Medicaid programs over to them. Other United and Aetna and some of the others are also in that business. And they now are getting United and I think Aetna and probably Cigna, almost all of them now get a majority of their revenue, not from the commercial or private side, but from the public sector, because they've been so successful in getting the states to turn their Medicaid programs over to them, and through the Medicare Advantage program and the Part D plans, to increasing amounts of revenue or percentage of revenue is now coming from the Medicare program, and they see that. I mean, that's their future. They, if you look, you're seeing that quarter by quarter, they're insuring fewer and fewer people in the private sector and more in the public sector. There's not much awareness of that and what the consequences of that are.
I have a list of people that I would like to thank. I'd like to start with Ed Weisbart and the Physicians for a National Health Program. Thank you for making this talk possible. And to our staff at the Bander Center, including Jason Kuhn, Denise Webb, our student managers, Matt Gracka, Annie Seskleifer, and Jeff Carbonella. Thanks to them for all the work they do. And thank you all for being here again on a Friday morning and making your time available.
Thank you very much.
Yeah, this was fantastic. And thank you guys again as well. So please stick around and join us for a discussion.